And here we go. So today we're going to talk about the neurobiology of psychopharmacology and mood disorders. And in that, we're going to deal with impulsivity, compulsivity, and aggression. Now, like I told you, this is a diagnosis of exclusion, and we don't have biomarkers or head scans to make this diagnosis. So, what we're saying is, in the absence of another explanation for the symptoms the person is having, that's what we're going to start to call, in this case, a mood disorder. So, what I want you to get out of this particular section of the lecture is when and what do you prescribe? We'll review the function of the neurotransmitters and the various 5-HT receptors and subtypes and their clinical effects. We'll do a little bit of switching and augmenting. We'll talk about relapse prevention after ECT, because that is one of the, what we're calling a psychopharmacologic agent, but really electricity. And then some emergent treatments for affective switching. We'll discuss what is affective switching. And the other thing is there's no pill for that, aka off-label uses for IED, OCD, trichotillomania, hoarding, kleptomania, and non-suicidal self-injurious behavior. All of the prescribing done for those later conditions, which may occupy a lot of your time as a psychiatric nurse practitioner, there's no official medication for them. So that's why the RDoC criteria with respect to the neurobiological circuits will give you some theoretical underpinning as to what to prescribe and why. Again, I will remind you, all of psychopharmacology is theoretical. And let's get to our first slide here. Okay, so the thing I want you to do, we need to kill this chemical imbalance theory. It still persists. It essentially got debunked on the day it was born, well, a couple of years later. This is a myth that's still alive in all clinics and a lot of textbooks. This is the idea that depression is caused by simple serotonin imbalance. This sounds neat, it sounds scientific, but it's wrong. This theory came out from early drug studies. There was a drug called risperidone, and early antidepressants found that, oh, this thing depletes serotonin and they get depressed. Therefore, depression must be due to low serotonin. So if we make a serotonin reuptake inhibitor, they should feel better. The problem is there's no real test for serotonin. We don't know what normal levels are for serotonin. Not everybody got depressed. So this caused us a problem in theoretical underpinning. What we're trying to answer here is what actually happens downstream. How does the brain adapt and rewire? Depression is not about one chemical. It's a system of disruptions in the circuitry. It affects sleep, appetite, mood, thought. And the problem is we keep clinging to this serotonin myth, and this keeps us from seeing the full picture of the patient. The other problem is, there's a reason it's only a 50-50 shot in the mild to moderate depression, and that's according to our best psychopharmacology research. So we're clearly missing something if we tell the patient, you have a chemical imbalance, and therefore that's why I'm giving you an SSRI, and therefore this is going to help you. Now, they may feel benefit, but we can't negate the placebo effect in that respect. Antidepressants also, interestingly enough, will increase your serotonin level within hours. So why are we telling them 6 to 8 to 12 weeks before you feel full relief at the full dose? And we normally start in a titration period, right? We start at a lower dose, we give them a couple of weeks, we hope for GI tolerability, then we go up on the dose, and we're telling them 6 to 12 weeks. Well, when you put that drug in the system, the serotonin goes up in a matter of hours. So what's going on? Clearly, it's more than just not enough serotonin in the system. Antidepressants will increase the serotonin level with hours, but mood takes weeks. And then the other problem is this depleting serotonin agent, this risperidone, did not reliably cause depression. It was just observed. It also was not an endpoint. It was more a side effect that was noted. So also, antidepressants work even when the serotonin is not low, but we don't have a normative range of what is the normal amount of serotonin in your body. So again, we're limited by the fact that we're not a biomarker discipline. We're trying to be, but we're not there yet. So this is the Risperidine paradox, the original basis for the monoamine theory, which is that chemical imbalance serotonin theory. That's what it's called, the monoamine theory. Later reviews found that risperidine may not cause depression in some cases. It may even reduce it in some people. And the study is there. You can pull up the antidepressant era from Harvard University Press. It's a book in 1997. That's how old this debunking has been, but this theory lives on. This essentially looks at the risperidine narrative and challenges this pharma-driven simplification. So what had happened was when this theory came out, it led to a lot of pretty cartoon graphics and direct-to-consumer advertising from the pharmaceutical industry. So we thought, okay, depleting monoamines causes depression, increasing it should treat them. This gained traction. And if it fit early drug data and gave psychiatry a biological model, which we had been hoping for all these years. Prior to this, we were doing Thorazine and asylums, essentially. So when the SSRIs came to market and their low side effect profile was known, we quickly jumped on this bandwagon, and we have a number of SSRIs out there. So this medicine this risperidine did not consistently cause depression, and sometimes it even improved the mood. And the story was never as solid as it seemed, yet this continued to fuel that neurotransmitter-based treatment that we have all bought into. I'm spending time on this because this is alive and well, and you will have to know this well enough to fight that uphill battle if you're going to be somewhat useful and consistent to your patients. So please be skeptical in any biology, especially psychiatry, of any theory that seems overly tidy. Especially when it aligns too neatly with a pharmaceutical or even nutraceutical goal. So be careful as you take in all this data as functional medicine gains track. There's a lot of aspirational claims being made about the nutraceuticals, and everyone should be on magnesium, and everyone should be on L-theanine, and everyone should be on MSAM and ashwagandha and all these other things. The theories are a little too neat. They're not that precise. They are equally speculative and theoretical. So please, the goal of me sharing this with you is to make sure you are sufficiently skeptical and that you can help your patient make better decisions. This serotonin theory of depression, this is a systematic umbrella review. This is another article by Monstereff. This is gaining traction again lately, or maybe just on my social media feed because I'm looking for this stuff as I prepare these lectures. But essentially this study from 2022, as recently as 2022, we're still publishing analyses to debunk and show how this theory is lacking. They took a systematic umbrella review of 17 studies that were large scale. They reviewed the meta-analyses and systematic reviews on serotonin and depression, and they found no consistent evidence linking serotonin levels to depression. No significant difference in serotonin activity between individuals with and without depression. The conclusion is that challenging the serotonin hypothesis of depression and questioning the rationale for antidepressant targeting. So this was a pretty large study of studies, if you will. That's what an umbrella review is. So you can jot the name down if you want to read it. By all means, pull the study. You can dump it into Google Notebook and interact with it accordingly. And you can upload other studies if you want to see how they work together. So that's a good way to do that. Eugene.
Would it be fair to hypothesize that depression can be like a subtype of psychosis, implying that people are just creating kind of a delusion in their minds of this depressive state of their life, which is why we augment some SSRIs with antipsychotics for treatment-resistant depression?
That's a great theory to consider. The problem is you are asking about depression and psychosis as if they are biological concrete things. And so if you were talking about, I mean, in theory, sure, that could be a manifestation. And sometimes depression and mood disorders get so bad that you get psychotic symptoms. And in those cases, they do indeed treat both the primary mood disorder and the psychosis with an antipsychotic. But what you need to keep in mind, and I'll repeat it again, because it's not because it upsets people, but it does upset people when I say this, there is no thing called mental illness. It's not a discrete entity. It is a social construct that we have based on a constellation of symptoms that in the absence of another explanation, we're going to label it a particular disorder as found in the DSM. So I appreciate what you're saying, but it's hard to make that to make that statement, because unless we can concretely say what is depression and what is psychosis, we have definitions, but they're not concrete entities.
So we can't classify it as a delusion, though.
Delusion could be a symptom of a depressive disorder or a mood disorder, or a delusion could be a feature of a psychotic disorder. But realize the DSM has a separate standalone diagnosis for delusional disorder that's not psychosis and that's not mood-based. So just because you have a delusion, it doesn't mean that you have psychosis or depression. What is a delusion? A delusion is a deeply held belief despite evidence to the contrary. Well, prior to DSM-5, you could be deluded about your gender. But in DSM-5 and 5-TR, a carve-out was made to say delusional disorder is, the definition is what it is, but now we have a carve-out for gender dysphoria. We've always had gender dysphoria, but we never went into it by treating it and going along with it. Now we're affirming it. Now, what makes one a delusion and not the other? That's a consensus statement. That's a very American, Western European. But if you take this to other parts of the world, that definition doesn't hold water there. So that's our perspective on that. Sharon.
Not to go totally off topic, but what about some of this work that's being done around fMRIs? I know that it's like 20 years.
Yeah.
They're talking about that they can see different activity in the brain, and then they use different treatments, and it seems to affect the different areas of the brain in people with severe depression.
That is a very fair statement. The problem is fMRIs are not used in diagnostic tools. Right now, they're just driving the theory. You realize fMRIs are a functional observation, right? We didn't have a baseline MRI. I mean, we do tests. We put you in the functional MRI. We record a baseline, and then we stress you out in some way and record what the brain lights up as. And we see this correlationally done. We don't know what came first, though. We don't know that it's our disease causing it or your predisposed brain causing it. We don't know if it's a state or a trait. We are speculating, essentially. So functional MRIs and that Amen Clinic, they offer a theory, and they provide pictures to go with the theory. But we're not there. We're not there. We don't have a clear understanding of what exactly this thing is. And that's kind of the biggest critique of the DSM, is it's all classification, essentially, without anything to neurobiologically underpin it. The DSM stratification criteria does not account for overlapping symptoms. That's how come a patient with bipolar can see one provider and get a diagnosis of bipolar, see another one, get a diagnosis of borderline personality disorder, see another one and get a diagnosis of ADD, see another one and get a diagnosis of PTSD. If you want to do a little AI exercise for yourself, enter into one of your favorite chatbots, your LLMs, enter overlapping symptoms for bipolar, PTSD, borderline personality, and have it make a grid of overlapping symptoms, and you will see how much can be overlapped. So really, it becomes dependent on context and the provider listening and their experience. So this is what makes psychiatry hard to do and contend with. You're basically trying to nail Jello to a wall. It's too many moving parts. So to that end, I always give you the preemptor: first, do no harm, and then do good. And the way you're going to do that is to be very selective as to what you prescribe and for what. Don't ever fall in the habit of saying this drug for that disorder. What you need to do is get in the habit of, you can say that disorder in your formulation, but when you prescribe a drug, you want to say, what specifically is that drug going to do? Increase eating, increase sleeping, improve concentration, reduce rumination, etc., so that you know how to follow up on it. Don't just say, SSRI, depression, move on. No, wrong. Don't do that. You will get into trouble in terms of the polypharmacy problem, because then people will keep adding on. Everyone's afraid to remove, and then you go down this this pipeline of I don't know what I'm doing or why I'm doing it, and you will inherit patients on these long medication lists, and you're like, how did this happen? How did we get here? This is a serotonin and depression disconnect between the advertisements and the scientific literature. So basically, this study here looked at the advertising and the scientific literature. This was a narrative review. And what happened here is they were trying to decide how antidepressants are advertised, especially when they claim they correct a chemical imbalance. They then compared that to what actually the literature said, and the result was a total mismatch. The ad suggested that serotonin is the cause of depression, but the peer-reviewed studies they cited say the exact opposite. They offered no evidence to support it. So this review doesn't present new data, but it exposes how the public and even professionals believe in the serotonin theory, and it's shaped more and more by marketing than science. So this is where your responsibility as advanced practice nurses and prescribers comes in. You need to be able to offer accurate, transparent explanations. And if you don't know, you just say, we don't know, but our theory is. Joanne.
I have a question regarding the advertisement for the medication. So before they advertise medication, I'm wondering if FDA or any institution don't take a look before, because they have to prove before they go on social media to advertise, because
Or anywhere, yeah.
they can do harm to patients. So I'm wondering if there is no significant clinical significance, can they just advertise drugs and people might just buy it and then they will do harm? So I'm wondering how FDA regulate the advertising regarding drugs, because there are a lot of advertising. There's a lot, and every day. So how they regulate the advertising? Because I'm one, because people trust social media. They trust them, and they buy the food, the medication or the food. So how the process goes on? I would like to know how.
So pharmaceuticals are regulated in terms of what they can advertise by the FDA. And that regulation has changed over the years as a result of lawsuits, case law, legislation from the government. When you take the health policy course, we'll talk about how health policy affects what you're actually doing. But suffice it to say, yes, it is regulated. And so you will find things like they have to pull advertising when they find it to be misleading. You will find things, for example, what they've done now is I don't do drug reps because they can't find me, and I don't keep an office where they can walk in. But suffice it to say, when the drug rep sees you to tell you about a medication, they're not allowed to tell you anything off-label about the drug. They have to only tell you what the study showed, right? But what else they can do then is the company's supposed to have this separate arm called the medical science liaison, and that person can discuss the science with you. They can't even bring up the drug name unless you bring up the drug name, essentially. And these are all regulations that the industry tries to govern itself. But suffice it to say, it's very restricted as to who can say what about what and in what capacity. So that's now why you're seeing these drug commercials. They'll say something like, this is what it's for, right? Beautiful scenery, beautiful music. But at the end, you'll hear a whole list of complaints and problems about it may cause death and blindness and watery wets. And that, right? You'll get that whole list of litany. So they say, okay, we've disclosed all the harms to you. But essentially, yes, it is restricted. But a lot of what happens is there's a lot of let's ask forgiveness instead of permission tends to go on. Yeah, Evelyn, what was your question?
Well, I was just going to say that just what you said, the advertisements on TV, I mean, the small print at the end of the commercial covers them. So they get away with this, manipulation.
For now, it's interesting because, this is a lot of what the FDA and is basically, this is the reason there's a lot of distrust in government and professionals and experts is for years, people knew various health claims were not true, and yet they were allowed to go forth. I mean, people are arguing this with respect to the food pyramid, with respect to public health recommendations, a whole lot of things. So I have always said your biggest predictor of a successful outcome is therapeutic alliance. Mm-hmm. And in order to have a good therapeutic alliance, that requires mutual respect and trust of each other. Part of that trust means when you say to the patient, I really don't know. This is the best we have given the information. There are risks that we may not know about. And you let the patient decide rather than trying to dictate to them what they ought to be doing, especially when we're not talking a life and death situation. I mean, essentially, there's no pill for compulsive sexual behavior. There's no pill for gambling. There's no pill for intermittent explosive disorder, right? And we're putting this maybe on children. Well, we didn't do research on children because it's not even FDA approved in the children. And yet here we are prescribing to them, and we are not being as transparent as we ought to be and say, look, we really don't know. We do not know the effect on the developing mind. Oh, let me put this on your radar real quick. There is coming debates regarding in the Medicare hearings, they're coming up where they're going to talk about the role of SSRIs in pregnancy. So pay attention to that. You might be interested to hear what they're saying. But yes, we say healthy mom, healthy baby. But on some level, there may be more to the story. Go ahead.
I was just going to say, I mean, Western American kind of society, they're focused on this magic bullet for almost everything. And a lot of education has to happen.
Well, not only education in the traditional, let me transmit information to you, but a lot of the psychoed that happens in your sessions will be in helping the person realize that not all suffering is bad. There may be a point to it, and I'd like to help you find that point so you can grow from it, because there is no growth without suffering. So what happens is, instead of trying to offer a pill to mute everyone's ill, we might have to say, you're having a normal reaction sometimes to a stressful life event, and let's develop some coping strategies. But we are very much in the instant gratification era. Give it to me now, bigger, faster, more is better. Sora.
Oh, I was going to say just that, because I work with kids a lot, and sometimes, you know, we're quick to pathologize a lot of the things that they're going through. And then sometimes I do the discharge and I meet the family and I'm like, oh, this child was actually remarkably well adjusted, because if I was raised in those circumstances, I would be way worse.
Yeah.
And there's nothing necessarily wrong with the kid. It's just the surroundings or the situation, but we can't handle the situation. So we're just going to medicate the problem away. And
you're exactly
we
right.
always do that. And or like sometimes I have a struggle when it comes to like, you know, when we have a situation that happens and we want to, like a crisis on the unit, and when it comes to medicating certain things, and it's like, I understand the need for medication, but like you can't medicate away 15 years of bad parenting. This isn't necessarily like the patient's not psychotic. They're just being a jerk. And that patient needs, you know, CBT, not necessarily Haldol.
Right. Well, you bring up a very good point, and I think I've mentioned this to you before, but in child psychiatry, the child is referred to as the IP, the identified patient. And the reason they do that is because that is the one that the family system has agreed upon to be the sick one. And essentially what they're trying to do is treat the family in the way by medicating the child. So I'll tell you this right now, if you want to do good child psychiatry, don't do the traditional one-on-one model with the child alone. You need to involve the family and whoever's in that home, because you may realize, like you said, you are basically having a normal reaction to a stressful situation given your coping resources at 7, 8, 9, 10, 11, 12, 15 years old with your underdeveloped brain, right? With your limited executive function. So on some level, you have to grant that child the benefit of the doubt. These meds are not benign. They're not without risk. They do have a time and a place, obviously, but I only put this out there to help you think more critically about what you will be presented with or what you have been presented with. Let me tell you about this meta-analysis of raw data submitted to the FDA from 35 clinical trials involving over 5,000 patients. Kirsch and his team weren't interested in serotonin per se. They were focused on whether antidepressants even work better than placebo. And what they found was that for patients with mild to moderate depression, the difference between antidepressants and placebo was statistically significant, but clinically meaningless. You know, so we talked about in the first few weeks the difference between statistically significant but clinically meaningless. You know, that's the type where, for example, yes, there was a statistical change found, but the improvement on the measurement scale was only 1 or 2 points. And so that's what happens. So yes, that's what allows the drug to come to market, is that it is statistically significant. And clinical really is a subjective assessment. Look, if the 2 points means a lot to you, then fine. If it doesn't mean a lot to you, but it's still a drug that's approved because the number said it approved. So only in very severe depression did antidepressants show a clinically meaningful advantage. And even then, it wasn't because the drugs worked better. It's because the placebo worked worse in that group. So if SSRIs were truly correcting a chemical imbalance, we would expect them to help mild depression just as much as severe, but they don't. And so this further undermines this biological simplicity of the serotonin model. So what is the model then? What are we doing here exactly? Well, now that I've beat this serotonin deficiency myth to death, hopefully, we're going to talk about the model that actually fits the data, and that is the concept of neuroplasticity. This neuroplasticity hypothesis, this is the idea that here, depression isn't just about the chemical level, it's about what chronic stress and emotional trauma do to the brain structure and function over time. Specifically, it's looking at the brain's ability to adapt and form new connections and then regenerate. We call that neurogenesis. So at the center of this model is a protein called BDNF, brain-derived neurotrophic factor. This is essentially Miracle-Gro for the brain. And this is supposed to help neurons survive, grow, wire together. So we have a line in psychiatry and psychopharmacology, what fires together, wires together. So if you continue to fire two things together, you will then cause a circuit pathway that makes that the path of least resistance. And that's what we think is happening when we try to alter the chemical process of the brain, set the chemical stage so that new behaviors can become habituated, so that a new neural pathway can be developed. That is to say, we increase distress tolerance, we reduce thrill-seeking behavior, we're less impulsive, we think about future consequences. All of that needs to be trained over time. That's why the pill does not equal skill immediately. So in depression, if it's a chronic or trauma-related BDNF level is said to drop, that leads to shrinkage of the hippocampus, disconnection in mood circuits, and then overactivation of the amygdala. And that's a lot of the premise that underpins that book, The Body Keeps the Score. I'm sure you're familiar with that. It's everywhere lately. Now, the twist is this: antidepressants don't immediately improve mood because they're not just fixing the chemical imbalance. What we're doing with these pills is we're starting a chemical cascade that eventually should lead to more BDNF and then restore that plasticity. But that's why it takes the 6 to 12 weeks. That's why there's this lag time that we tell people that's when you may notice improvement. Now, what's happening in that process of taking the pill for 6 to 12 weeks? Well, there's the ritual of the taking of the pill. Now you have structure in your day that you suddenly were lacking. You're coming to follow-up appointments, which means you're showering, getting dressed, showing up on time. You're keeping a schedule. You're out, so now maybe you're engaging. And now you're doing other healthful things for your body. Maybe you are taking that walk. So you see what's happening is sometimes that pill becomes the trigger action for subsequent behaviors, which can hopefully become habituated. So that's where things like exercise, psychotherapy, that's why psychotherapy can also trigger neurogenesis, because psychotherapy is supposed to be therapeutic stress, essentially, to help you grow in that other direction, to make you more adaptable. Ketamine is one of the ones that tends to really increase BDNF quickly, which is why it's got such a rapid relief of symptoms, because it surges the BDNF and it's supposed to enhance neuroplasticity. But I will tell you, not a panacea. People are doing ketamine for life, essentially, weekly, and that's not ever how it was tried. There are aftermarket reports that show people continue on it. But really what we're talking about is, can we build that BDNF on our own and maintain that adaptability? So we have to think beyond pills, and we need to really start targeting root causes. So BDNF is essential, as you can see, for learning, memory, emotional regulation, and the like. So I want you to reframe your understanding regarding the mechanism of antidepressants. What we're saying, here it is in short form, we're triggering a cascade that increases BDNF and synaptic growth. It reverses stress-induced neural atrophy. And atrophy happens with you don't use it, you'll lose it. So one of the articles that came out was that people that are on long-term serotonin may lose that part of the brain, that synaptic function that actually produces serotonin, because you're limiting the reuptake. And if we're a negative feedback system, we only make what we need. If we don't need it, we don't make it. And so what happens if you do that for years is you may atrophy that synaptic pathway that leads to production of serotonin. Other treatments that boost BDNF include exercise, ketamine, psychedelic assisted therapy, which is experimental, psychotherapy, CBT, mindfulness, exposure therapy can work, and then ECT as well. But that is the theory behind what's driving this. And some of you may think, well, why does it matter? It's all a theory. Well, what are you going to tell your patient? You need something to tell them. And some might say, it's not a battle I want to fight. If they want to believe chemical imbalance theory, I'll go with it. If they want BDNF theory, I'll go with that. Suffice it to say, it's helpful to be as honest as we can and to drive home the fact that this is all theoretical, but this is our best understanding to date. So how do you talk to them about antidepressants without the myth? So something you can say is, we're not fixing a chemical imbalance. We're helping your brain become more flexible and resilient. I may have told you early on, one of the big hallmarks of mental illness is mental rigidity. If someone is very fixated and can't shift and can't entertain another perspective in their thought process, that's a tell often that there's something more going on there. Eugene.
So just to clarify, you're saying that if people avoid stressful situations in a general sense, they lose the ability to handle it when they are in a stressful situation, making them like weaker to control their emotions and their mindsets?
Right, because those are all skills to practice. See, this is the problem with the failure to launch kids. See, what's happened is you have very affluent parents that have gone from helicoptering, which was the old days. Now they've gone to what they call lawnmowering or paving. So this is such that they're not preparing the kid for life. What they're doing is they're using their resources to pave the path for the kid going forward, and the kid never learns to adapt and bounce back from upset and disappointment. And so they can't handle stress because they've never had to handle stress. On some level, as much as you say the kid needs to get up and move out, on some level, it's a little not fair. He never was taught. He was doing the best he could, given the parents he was given, as affluent as they may have been. But in therapy, you're going to support both the parents and the child to help them grow and to learn distress tolerance and to let them try and fail and try again. That's the work that goes on in these weekly sessions. Hopefully, it's supposed to go on. What else goes on is, tell me about your feelings and how was your week, and we run the meter, 45 minutes is up and see you next week. That goes on a lot more, sad to say. And then what you have is people in therapy for life and no one's making progress. But
there's been no studies, right, that tested high stressful long-term environments to lower depression levels.
It's not that we put people in high stress environments. And you can look at things like, if you look at military training, survival, escape, rescue training, what they call that is stress inoculation. And so you can inoculate small levels of stress along the way to see how you survive. I mean, think about this from very early on when you want to sleep train an infant. That infant needs to experience some stress in the 4, 5, 6 months of early life and learn to self-soothe. And then eventually they can handle going to sleep. But you have parents that do this co-sleeping thing. And, when I was working at the partial hospital for adolescents, I had adolescents still sleeping in the bed with their parents because they never learned to self-soothe. And these are not functionally disabled adolescents. These are adolescents that attend some of the city's best high schools, Stuyvesant and Bronx Science and LaGuardia and the like. But they're sleeping in the bed with their parents because they can't be alone. So there is no distress tolerance. Or they don't choose a well-rounded panacea of distress. It could all be academic stress that they can tolerate, but they can't tolerate, what do I buy to eat? I can't make my own bed. I don't know what to pick. I can't navigate the trains. I mean, you choose your stressors, essentially. That's the other thing, too. People believe that confidence needs to happen. Confidence is a skill. It only comes by doing. There's no pill to give somebody I mean, you could do liquid courage, and they do impulsive things, but the act of developing confidence requires you to fail and come back and keep practicing. That's how confidence is built. And so the whole point of these medications is, if the feelings are amped up too high that we're not able to learn the skill, then the exit plan may be, we will medicate for now with the goal of coming down, with the hope of developing your distress tolerance and building your resilience as we wean these meds. Okay. So this essentially now shifts the focus from deficiency to promoting neuroplasticity. That's the essential take-home message here. Okay, let's take a look here at the neurotransmitters and their functions. So here is the list of neurotransmitters that we're generally concerned with in psychopharmacology: serotonin, dopamine, norepinephrine, GABA, glutamate, and acetylcholine. So GABA is inhibitory, glutamate's excitatory, and the key functions they control are also listed here: mood, reward, energy, inhibition, excitation, cognition. And what we believe is if there are deficiency states, that you may have these symptomatic manifestations. That's the theory that is alive and well. Now, what happens if you have too much of these things? Well, you know, too much serotonin typically leads to sexual dysfunction and insomnia. So that's not uncommon when you start somebody on an SSRI and you suddenly derail their sleep. And so that's why some people will combine it with a benzo or a gabapentin or an antipsychotic second generation during the titration period of an SSRI. That's not uncommon. My recommendation is that you not use the benzo as your first line. They're very enjoyable, highly addictive, and hard to use anything else to treat anxiety once they've been on a benzo. There's going to need to be a withdrawal management / detox process there. The clinical relevance by targets. So the SSRIs, these target receptor specific, and I'll show you the 5-HT chart on the next slide, HT1A, 2A, 2C, and 3. Dopamine, this modulated by stimulants and second generation antipsychotics. So, you know, those block them. Second generation antipsychotics block the dopamine, and you can see what happens there. It blunts everything essentially. And sometimes you want to enhance it if you want to promote motivation and drive and the like. So you're talking essentially bupropion versus some second generation antipsychotic when you're talking about how do we manipulate the dopamine. Norepinephrine, these are very popular as well. Some meds are both SSRI and SNRI depending on their dose. So for example, venlafaxine primarily is SSRI until you get up to about 175 to 275, depending on the individual, before you get SNRI activity. So it's not, it's not clean. It's also very hard to come off of because of the major SSRI component at the lower doses. GABA, our favorite one is gabapentin, but essentially you could put the benzos in this class as well as valproic, because these are all inhibitory neurotransmitters and chemicals. And then glutamate would be ketamine and memantine. These are given to enhance cognition, promote neuroplasticity. Again, nothing is without side effect. And then acetylcholine, we talk about there in terms of memory consolidation, sleep, dementia, etc. So those are the neurotransmitters that are at play. Let me review here these 5-HT receptors and their subtypes, because you will notice on certain medications, like if you look up, say, ondansetron, which is given for nausea, you will notice that that affects the 5-HT2C receptor and the 5-HT3 receptor as well. Why that matters is because your patient may be, say, on serotonin for something, and then the problem is they get combined with other medications. So this is how we get trouble with something like serotonin syndrome. Other agents may be affecting these receptor subtypes, and then what you get is a compounded effect. So that's why it's important for you to know when you look up the medication, the first thing you need to do is look up the mechanism of action, and that's where it'll tell you about the 5-HT. The other thing you need to look up is the half-life, so that you know how long it's going to take for this drug to last in the system. And then the other thing you want to look up is the metabolic pathway that it goes through the CYP450. That will give you a lot of insight into that medication. So when you're getting a new consult patient on a list of medicines, I strongly recommend that your medication reconciliation extends to that much. Half-life, mechanism of action, metabolic pathway. And then you can consider all the other meds they're on and their underlying medical conditions. This is how understanding this process is what allows you to effectively deprescribe. And I'll tell you, most of my practice is deprescribing, not prescribing. I get a lot of people on a whole list of medications that nobody seems to be willing to go through this list line by line, mechanism by mechanism, pathway by pathway to clean up the med list. And so you have a lot of incomplete titrations and bad crossover, and then delirium in the elderly often. And the patient doesn't feel better. So psych is short for psychiatry, not psychic. And the reason I put this here is because the only way we know anything is by asking. I don't know what's going on in your head or body unless I ask and you tell me the truth, which means I need to build a sufficient therapeutic alliance that you are going to tell me the truth so that I can help you. So now we're going to ask some questions as we go through this here, because I've been doing all the talking and you all have the notes. So let's hear from some of you. Who can name 2 common side effects of an SSRI and explain the receptor mechanism behind them? That's on your notes. You have the 5-HT. Let me go through here. You can use your hand emoji. Go ahead, Mr. Bott. Let me hear from you, sir.
So you just like it's nausea, like GI symptoms, and what do you call this thing? Sexual dysfunction.
Yeah, those are the most common ones. And which receptor, which 5-HT receptor is linked to those?
It's 5-ST3.
And you said the sexual dysfunction. Which one's linked to the sexual dysfunction too?
Let me just review the note.
This is the one associated with arousal and sexual function / dysfunction. Go ahead, Mr. Buck.
Sorry, I just have to look the note. I forget.
Put your hand up again.
Wait.
Who can help them out?
Oh, yes. Is 5-HT2A.
That's right, the 5-HT2A. So why this matters is the most common reason people go off their SSRIs is sexual dysfunction. That's the most common reason. People will ruin their sleep and all kinds of stuff, but it's the sexual dysfunction that tends to be the main reason people stop the SSRI. There's a book out called Lost Connections. I highly recommend it. It's by Johann Hari. He talks about his journey of when he felt depressed in the UK and he was started on an SSRI and all the downstream effects that happened that it was supposed to fix. And in relation, it turned out making things worse. Go ahead, Kurt.
Just wanted to add, does also serotonin levels also affect your dopamine levels, which affects your libido and your arousal?
So dopamine is about desire and reward. What's going on here? I think I clicked something. Dopamine is about desire and reward. So it can be affected because basically these are negative. These are feedback loops essentially. So it doesn't necessarily inhibit it. The problem is serotonin causes a feeling of satiety and contentment. There was a Sex and the City episode, a long time ago, the old season, essentially, where the man she was having sex with was on an SSRI. And she was working very hard to get this man aroused so they could have sex. And he just kind of seemed pleasantly, well, it's okay. I'm not that interested. All righty, then why don't we just stop for now? And she was taking it as a personal offense that he wasn't attracted to her. And this is interesting, too, because when you treat the patient, you realize they're attached to a system. So she was taking it personally that this person was not attracted to her, when in reality, he was on SSRI and it wasn't going to get up anyway, no matter what she did. And as a result, the relationship failed because of the sexual dysfunction. Sexual dysfunction can be a major impetus for demise of marriages, essentially. It's the 2 most common reasons are sex and money. And so it's worth having a systems-wide conversation as to what effect this is happening. Yes, you're feeling better, but you're not able to meet the sexual needs of the relationship that you're in. And so we may need to make a change based on that. It's not enough to just simply feel better. We want you to be living a better life. We want you functional. Your feelings aren't the most important thing. What you do, your sense of purpose, who you're connected to, that's the most important thing. So that's something to keep in mind. Okay, let's talk about this one here. Which SSRI has the longest half-life and why is that clinically useful information? Go ahead, Kira.
Fluoxetine has the longest half-life, and it might
Yeah.
be helpful in patients that may not be adherent, may not be taking the medication every day, because if they miss a dose or two, they won't get severe, side effects.
Yeah, that's helpful to know. Cordell, what else you got? Did I see Cordell's hand?
Yes, you did. So pretty much I was going to say what Kira was saying.
Right, but why is that clinically useful, Cordell? Why would I like that to have such a long half-life, other than missing a dose or two?
Why? Because it does help to reduce like the severity of withdrawal symptoms, and
yes,
there is a potential for like less frequent dosing if it's something a patient could take like maybe weekly or once a day, or it's not something that they repeatedly take in.
Right. Let me ask you this question. This is kind of a backdoor way to ask this, and then I'll hear from Evelyn and Sora. If a patient suddenly stops their SSRI and reports to you that they're having brain zaps, I can't remember what I was taking. I was on an SSRI. I don't know what it was, but now I'm having these brain zaps. What drug can you eliminate likely from your differentials that they were likely not taking? What were they likely not taking? Which SSRI were they likely not taking? If they tell you that.
The fluoxetine?
Yeah, exactly right. The fluoxetine, because of the long half-life. It's about 4 to 6 days. It's a natural taper. We use fluoxetine to help get you off of other SSRIs if you're having a lot of withdrawal and the like. Yeah. Let me hear from Evelyn and then Sora.
Well, I was going to say it would impact also if you're switching to another class. Like
right.
if you're switching to a MAOI, you'd want to make sure that fluoxetine was out of the system, right? So
that's exactly right. So there's an expected 14-day washout period for SSRIs. When you're doing fluoxetine, I strongly recommend you make that 14-day washout period start after day 6. Essentially, to make sure it's completely washed out, because at day 6 it's half in the body, day 12 it's a quarter in the body, right? That's why I'm telling you want to start your 14-day clock at the end of the half-life cycle. Other drugs, it doesn't matter so much. Your half-lives are 12 hours or less or whatever, or 24 hours, say. Not a big deal when you're talking a 14-day washout period. But when your half-life is 4 to 6 days, you need to remember to start that washout period on day 6, because you don't want to overlap it with an MAOI, and then we have all of those downstream effects. Okay, when should pharmacologic treatment be initiated in mood disorders? How do you know when to start treating people? What would make you treat someone? Go ahead, Eugene.
I would say when patient symptoms start interfering with their activities of daily life.
Yeah, when they start having functional deficits. What is it you can't do? Go ahead, Kurt.
I was going to say same thing, functional impairment, safety concerns, yeah.
Seema, do you have anything more to add? Joanne, anything new to add? Sora?
The externalized symptoms.
Yeah, that's good when the symptoms start spilling over onto other people. Yeah. Sora?
Less than sometimes the patients come in very resistant to trying therapy, and they're convinced that only a medication could work. And I wouldn't say that I'd medicate just because a patient wants medication. Like, I'm not going to go give a patient Adderall because they insist only Adderall will work. But sometimes putting them on a low dose of an antidepressant, is what you need to get them in the door to try pharmacologic options as well. After, assuming it all is after affecting their activities of daily living, et cetera, et cetera.
You're exactly right. So here's what happens, though. Because we live in a payer-driven world, the payer may not be willing to pay for your visits if you don't start them on a medication. That's often the case in hospitalization settings. They're not willing to cover a hospitalization, which may be therapeutic in and of itself because of the milieu, because of the structure, because of the groups, because of the activities, because of the distraction. But if you don't start them on a medication, they're not going to be wanting to pay for that hospitalization. So we do live in a put something in the system so that I can feel we're making progress. That's how come you will see if you work inpatient and they do these team rounds and they're just merely trying to extend the hospitalization, they'll do things like minuscule dose adjustments in the inpatient setting. Minuscule, clinically insignificant, not written in the literature anywhere. Or if it is, the benefit's not from the drug, it's likely from the prolonged therapeutic engagement and that sort of thing. So that's something to keep in mind. One thing to keep in mind is if a patient says to you, I'm depressed, a good question to ask is, how do you know you're depressed? How would I know you're depressed? What you're listening for is what it is they have organized in their mind that constitutes this thing we're calling depression. And the reason you want to ask, how do other people know if you're depressed, is you want to know, is this really spilling over, or is this just some sort of internal delusional framework that you're having? I'm depressed, but I go to work and I keep my activities and I do all the things. And you will notice the social media is now running awry with this thing called high functioning depression. Have you heard this phrase? High functioning depression. I can fulfill all the roles in my life and produce and excel, but I'm depressed. Go ahead, Eugene.
I think that goes back to what we were talking about earlier about people not developing the ability to handle stressful situations, and the medication becomes kind of like a placebo effect in their minds where they decide like, I can't start improving on my own without the support of something else beyond what I'm capable of. Considering that I'm not capable in my life, without your therapy, how can I handle this without medication? Kind of like how some people will say, hey, I'm not going to go exercise unless I'm taking protein or creatine. I'm not going to be able to gain gains or make strides without the addition of something else, even though that something else might not be contributing as much as the actual exercise or the therapy that they're receiving. It's just kind of like, again, the placebo of being able to rationalize doing the major part.
That's right. And that's why I spent like in the first 2-3 weeks of the course, before we even got to the drugs and conditions, we did a whole day on placebo and nocebo effect. That's for that reason. So you're hitting on it now. So I'm glad to see you bring that in. Cleo and then Gilbert.
Okay, I was saying, Eugene answered some of the question, but I was saying to initiate the mood disorder medication, doesn't we have to use the questionnaire for the patient also, the PHQ-9 score?
So that is none of those tests are diagnostic tests. They're all screening tests.
Oh,
so
okay.
Because they come up positive on a PHQ-9, they indicate depression, but you're now doing a psych evaluation where you're getting more of a history than a checklist. And so you're hopefully able to provide some sort of context to the situation. See, this is the problem. It's much easier to do what they call checklist psychiatry. This is how primary care does it because you only have 15 minutes in the visit. Fill out this PHQ-9. Oh, look, you're positive on 4 or more. Let me put you on an SSRI and refer you to psychiatry who can't see you for 6 to 12 weeks. God bless and goodbye. And we call that mental health care. That's what we call mental health care. Gilbert.
It's just that, it's funny that you say that because I've been getting a lot of ads about high functioning depression. And, and it and it makes you feel, when you're doing things that you would say in society that is having a good effect on society, whether that's going to school or you're in a field in where you have satisfaction and you're getting in your Pilates class and you're doing this, but all these claims are like, if you're functioning at a high level, you still have depression, you still can have this, click on this link, and it's just like, really, like, I don't know if it's a marketing thing. I would have to look at the literature on it, but
of course
it's just
marketing.
Like it makes you think, like, am I depressed?
We're not prescribing enough meds. Let's get more people in this market. We're fishing for a diagnosis. Sora, go ahead.
And another interesting thing when people come in and saying, I have high functioning this or that, is finding out what do you consider high functioning? Because if high functioning means that you can get up and go to your job and pay your bills, I'm glad for you. But then if you come home and sit on the couch because all your motivation is gone and your family life is falling apart, then you're not high functioning. You're functional, yes, but like you have a lot more to go.
You've just described most of Gen X parents right there. We function just fine with our neglect. Right? That's a way of functioning. On some level, you have to, interestingly, if you have downtime, look and see when the word parenting entered the lexicon. The concept of parenting is a very American, Western, modern, affluent, post 1950s idea. It's very American to think that you need to sit there and entertain your child and engage with them and stimulate them and nurture them and all this sort of stuff. You realize up until our affluent times, being a parent meant keeping the kid from dying, period. And you didn't always do that well enough. Right? And what happened? The kid was unparented? No, the kid learned that societal expectations meant I had to do X, Y, and Z in order to survive unto adulthood. And so now, as a result of our first world problems, we are not functioning high enough if we don't over enrich and overstimulate and enroll and do more and achieve more, etc. Right? So if we are not doing all of those things, we call it bad parenting. On some level, it's exhausting at the end of the day. When I've heard 8 people's problems and I come home and sit on the couch and my wife or child want to talk to me, honey, I can't handle anyone else's problems anymore. The meter's off. I can't hear another story today. Or does that mean I'm not high functioning? No, it means I'm tired today. And what will happen is you will find that people will try to turn that into a pathology. Physical fatigue is real. It's not a disorder. It means I need rest, I need a meal, I need a nap, I might need a steam room or a hot tub, and then maybe I'll feel energized again to hear your problems. So that's something to keep in mind. We like to pathologize reactions to life events. But your point is well taken, Sora, essentially. And I'll just drive it home further. You get into issues of workaholism where they're very high functioning at work, but they come home and they're all checked out. And they just may not be stimulated by what is going on in their home life, or they may want to work more to avoid whatever stressor is going on. So I would be curious to know why they're checked out, rather than just saying this is an example of low functioning. What if you are checked out because you come home and it's a constant nag fest? Or what if you are checked out because like the pile of settling your loved one's estate because you're the adult child of someone that died, and now the last thing you want to do is deal with it. So I hear what you're saying, though, Sora. It's multiple domains, by the way. You'll notice also when you make a diagnosis for something like ADD or oppositional defiance, you need to have the symptom in more than one domain.
Well, that's what I was thinking of with the multiple domains for ADD, ADHD criteria, but it might not. So sure, maybe you're, not as functional in some domains, but like doesn't necessarily mean that medication is a pharmacological answer. Let's look at the domains that you are functional in. Why are you functional there? Is it the high environment and there's just no stakes if you don't fold your laundry at home, so you're not prioritizing it, and that's where the executive dysfunction comes in? Then let's gamify your laundry. Like,
or maybe you don't value doing the laundry. Right. Or maybe you don't value it enough to do it. Or maybe you'd just rather work an extra hour and hire someone to do the laundry. Right? I mean, it depends. What is it you're valuing? How is it incongruent with, in fact, start first of all, what are your values? How are you living your life? Is it congruent with your values? That's how you do the motivational interviewing and develop some of the discrepancy to motivate change along the continuum. Gilbert, and then we're going to this question. Do you have something more or no? Your hand is up.
I think I forgot to put it down.
Put your hand down, Gilbert. Evelyn, do you have something more?
No, it was just going back to what you were saying. Like with one of my kids, she was like complaining about something, and I guess I wasn't validating her feelings. So it goes back to it can be a generational thing too,
Shame.
And I'm like, well, my answer to her, well, what doesn't kill you makes you stronger, So go get on with it,
Yeah, that's somewhat true on some level. It's great if you can help someone build their own internal validation system. And depending on the age of the kid, you need to do that for them to a time because they're too young to have developed it. They're only going to develop it from you. But that being said, it's really important to keep in mind that feelings are not facts. They come, go, and change. The feeling you want me to validate now will be gone by the time I get to validating it. So exactly. I hear what you're saying. I don't want to overvalue someone's feelings, but at the same time, I don't want to negate them. I think they're information and they're feeling them for a reason. Yeah. Let's talk about these drugs now. These are the popular classes in mood disorders. So what are some key differences between SSRIs, SNRIs, MAOIs, and second generation antipsychotics? Let me hear from Joe. Hi, Joe.
Hey. So SSRIs, they are thought to work by increasing serotonin levels in the brain. and they're typically first level, but we know from our BDNF that they probably help with neuroplasticity, all of these. SNRIs also boost serotonin levels, and they boost norepinephrine. So they can sometimes be used, for pain or attention, and energy, but they can sometimes cause blood pressure issues from the norepinephrine. MAOIs are older. They work mostly by blocking the breakdown of serotonin, dopamine, norepinephrine. But they have a lot of dietary restrictions and more dangerous interactions. So sometimes they're best to avoid unless people are pretty resistant to the others. And then second generation antipsychotics are more often used for mood disorders, but sometimes used for depression because they target dopamine and serotonin receptors. But they can also come with their own risks like metabolic syndrome, sedation, stuff like that.
So you're exactly right. Thank you for breaking all those down. So I will say this, if you can look at SSRIs, SNRIs, MAOIs, they all basically make more of the neurotransmitter available in the system. The SSRIs, SNRIs do it by inhibiting the reuptake of what's naturally produced. And what the MAOIs do is they inhibit the breakdown of what is naturally produced. The net effect is you have more of that neurotransmitter in the system. So that's exactly right. Thank you for all of that. And so other things to keep in mind, especially with the SSRIs that tend to be most common, is this thing called the poop out effect. Anyone familiar with the poop out effect? I'll just tell you what it is so we can get to the next thing. But this is basically, you've been on a drug for a long time and you essentially poop out. It loses efficacy. They also call this tachyphylaxis. So essentially, what was working well at one time has suddenly stopped working and we don't know why. This is a similar phenomena to when you oversensitize the receptor, say with the stimulant drugs that we talked about in cognition. One of the ways to mitigate this is to cause drug holidays. It's easier done with stimulants because those half-lives are much shorter. It's harder to do in these SSRIs because the half-lives are longer. And then, of course, there's the withdrawal to contend with. So drug holidays are not necessarily a viable option for contending with poop-out effect in these medications with the longer half-life. Sometimes you just have to change agents to something else. Or, try coming down and see if they have a different response. The other thing about the second generation antipsychotics, while they are approved, all of them now, I believe, are approved for monotherapy for what we call bipolar disorder. But in terms of major depressive disorder and the like, we typically use them in the place of augmentation. In other words, to enhance an effect of an already prescribed drug for someone that's partially responding. Other strategies include using things like lithium or second generations for augmenting. Now, when you use lithium to augment an antidepressant, this is not that we're aiming for a therapeutic lithium level in that case. We're really only aiming for a therapeutic lithium level if you're dealing with something like mania. There, we're aiming for a therapeutic level for geriatrics 0.6, everyone else 0.8 up to 1.2. Over 1.2, we're going to call that toxic. But that does not mean you don't do therapeutic drug monitoring on somebody that's on lithium augmentation, because you still have to look for toxicity, renal insufficiency, and the adverse thyroid effects. So even if you're not aiming for a therapeutic level, you still need to check the level if you're using lithium to augment. And then you also have that whole host of other potential adverse effects you need to monitor for while they're on it. So if you're going to use the drug, the intention matters, but the monitoring is not negated. Let me see here. The other thing to keep in mind is if you are going to do this, keep in mind what those symptoms of depression are. You may have anhedonia, poor appetite, poor sleep, etc. Well, if you're treating the depression, those things that they made them say depression should improve. But keep in mind, you could metabolically derange them with these second generation antipsychotics. So you always want to think about, if I'm going to start you on both of these, say it's a psychotic depression, I need to have, and I should be thinking about an exit plan as to when I can come off the antipsychotic part of these things because of the downstream metabolic effects. So whenever you start a medicine, another thing to consider, in addition to mechanism of action, metabolic pathway, half-life, adverse effects and side effects, of course, is what's the long-term plan for coming off? And you want to spell that out in your notes because you want to help the next level of care have an idea of what your game plan was. I see a lot of poor notes that come out of hospitalized patients or from office practices, not office practices so much, more hospitalized patients. We started this, we don't have an end game in mind. And so now you're left in the community in a less supervised setting trying to figure out how are we going to get this medicine off if that was even the plan. So just something to keep in mind when you're documenting in the future. So let's ask you this question now. How do you choose between and within an antidepressant class? How do you choose one over the other? Let me go through my list here. I've heard from a lot of the same people here. Let me hear from Cordell, and let me hear from who else has their hand up here? I want to hear from Cordell, and then I want to hear from Seema. Go ahead.
Choosing, does it depends primarily morely on the symptom that you're targeting more than anything else?
I need you a little bit louder. Open your mouth and talk a little bit louder, Cordell.
Does it primarily the symptom that you're trying to target more than anything else?
Give me an example.
Oh, if the person is not sleeping, then that's going to be the antidepressant that you're choosing. That's going to give you the best.
What might you choose?
For sleep, something like quetiapine.
A second generation antipsychotic like quetiapine. Okay.
No. Seroquel. Sorry, Seroquel.
That's quetiapine. You're right. Seroquel is quetiapine. That's a generic name. Yeah. Okay. Good. I'll take it. Who else? Who else is on my list? Let me hear from Seema.
Hi. I would start with probably a very patient-centered. Start with a patient-centered approach and discuss my assessment with them in addition to their assessment of themselves, and then make my suggestions and see what they know about the drug that I'm proposing. Let them know of any side effects. And I'm really thinking about the sexual side effects with this, because I might have mentioned that I worked for a company that specialized in medical malpractice, and I heard a lot about that. So I would give them informed, a lot of information. And then if they expressed hesitancy towards experiencing any of those side effects, I would try to pick something different that would also address, like maybe bupropion for like an SNRI instead of SSRI for depression.
Seema, tell me a little more about that when you mean medical malpractice with respect to sexual dysfunctions. Mm-hmm. Just give me a thumbnail sketch of that.
Sure. I spoke with, I didn't even know about this. This was before I even thought about going to this program. But I didn't know about SSRIs causing sexual dysfunction until I worked for this company. And we would have people calling us wanting to sue, like class action lawsuits against SSRI creators, for creating this drug that resulted in potentially lifelong sexual dysfunction.
So this is sexual dysfunction that did not go away even after they stopped the medication.
That's correct. At least sometimes for years is what I heard from some people.
Interesting. I hear that a lot with the finasteride, actually. You hear that, and there's a condition called finasteride discontinuation syndrome. It's not written up anywhere, but it's certainly documented in the literature. It's not an official diagnosis, but people that are on finasteride, which is Propecia, long-term, they're growing hair, but the libido's gone. There's no arousal. They're having all kinds of sexual dysfunctions that don't seem to be bouncing back. Go ahead, Joanne.
I think patient preference might be an option, prior treatment history, and also, as we know, unfortunately in this country, like we know that not everybody has insurance coverage, and we have people like we don't have that money. I'm wondering if I should consider also the cost and the insurance coverage regarding which one to choose.
That's fair, but I would look at, you're exactly right. You do have to consider affordability, access, all of those sorts of things. But what I was really trying to get at is, in general, all things being equal, assuming money is no object. It always is an object, but for our purposes here, the way you would choose between or within antidepressant class is essentially based on the symptom cluster. What is the constellation of symptoms that you're having? Anxiety, apathy, insomnia, as well as side effect profile and comorbid conditions. And then also, like you said, past experience and patient preference. All of those factors will play into what do you choose and what will we monitor. So that's all very good. Did you have something more, Seema? No? Okay.
No, sorry, let me put my head down.
All right. So how do you decide when you should switch versus when you should augment an antidepressant treatment? Let me see here. When should you switch? Keenan, and then Suyin. Let me hear from you guys.
You would switch antidepressants if there's a lot of intolerable side effects.
Okay.
Or if like for example, Prozac, there's a black box warning of suicidality. So if a patient like expresses increased like suicidal thoughts or anything like that, you would switch off of that.
Okay, good. Intolerable side effects is a good one. Yep.
And then
yeah.
Sorry. Just with the augmenting, if there's a like if there's another symptom that you want to address, like if there's a like comorbid anxiety, you would augment with another medication.
So augmentation is really intended for what we call partial responders. So people that have had some positive effect in the direction you were aiming for, but enough time has gone by and it's not a full effect, then you would augment to hit that initial symptom more fully. Because you've had some response. That's the reason you would augment rather than switch in that instance. They were moving in the right direction. You need just a further push. Whereas switching, like you said, intolerable side effects, definitely a factor. What else? Suyin.
I think the already Kenan said, the first thing I have to consider is the patient's response. If there is no response, yeah, consider switch first, and when partial response to the previous initial antidepressant, then I will consider augmenting. I think that's
that's another reason to switch. That's exactly right. If there is no response, if you didn't get better at all, there's no improvement and enough time has gone by, that would be a good reason to switch. When you switch, depending on how long you've been on the agent, you may still have to do a weaning / cross titration because even though there was no therapeutic effect, they may still have withdrawal from the agent. So just keep that in mind. Okay, let's talk about this one here. What is the clinical relevance of the different 5-HT receptor subtypes? What is their clinical significance? In other words, tell me the receptor subtype and what the downstream effect would be. Javi, do you have that by chance?
Sure, yeah. I mean, I guess different SSRIs sort of might affect some of the 5-HT receptors more than others, and so you can be targeted with that when you're picking sort of what SSRI to use. Also, when you're wanting to mitigate certain side effects. So, if you are wanting to, the patient is very concerned about the sexual side effects, that you want to sort of avoid the SSRI that's really, and I'm forgetting which one, but the one that really is more likely to cause, is it Lexapro that causes the most?
Fluoxetine's pretty big, Paxil's pretty big, but basically anything that hits the 5-HT2A receptor, that's the one that's going to be most implicated in sexual dysfunction and insomnia, essentially. Right. So,
right. Yeah. If someone is really struggling with insomnia, on the other hand, maybe you want to give them, Remeron, et cetera, trazodone, which we don't really use for depression, but.
Right. Well, they have the indication. Interestingly enough, trazodone does have the indication, which is Deseril, by the way, does have the indication. The problem is people cannot tolerate the GI upset side effects at the dose necessary to contend with the depression. So the depression dose for Deseril, which is trazodone, is about 400 milligrams.
Oh, wow.
High. Most people are using 25, 50, 100. The most is 200 for that drug. And then also the problem is it's sedating. What were you saying?
Oh no, I didn't know that there was Deseril and that people use trazodone at a dose of 400. I had just assumed you just sleep all day.
Yeah. Well, that's the problem though. The GI affect is too bad and the sedation is too much. And so it doesn't have a good, it's not typically used. It's more like it's in the market, it's in the pipeline, but most people use it off label for sleep or PRN during the day for anxiety at 25 to 50 milligram increments, something better than a benzo. So if I need something to sedate non-benzo, trazodone is a viable option. Mind you, it's off label, but something to keep in mind. Right. The other subtypes are the 5-HT1A, which is mood and anxiety, 5-HT3, which is GI upset. Those are the downstream effects of those drugs. So just keep that in mind. And then also if you mix and match, so, SSRIs with opioids, something to watch out for serotonin syndrome, SSRI with ondansetron, which is common for nausea. And why this matters is the most common adverse effect of an SSRI is nausea. And she said, oh, I'm nauseous, I can't keep taking this pill. Well, you may be tempted to give them something for the nausea, but if you give them Zofran for the nausea caused by the SSRI, you set the stage for delirium and serotonin syndrome. So be careful in doing that. You might have to try something else, Compazine or Reglan or, something like that. But keep in mind, metoclopramide, which is Reglan, also is implicated in movement disorders. So you have to be careful when you combine, say, that with a second generation antipsychotic or a first generation, because now you're compounding the risk for movement disorders. So the drugs are not benign. If you find yourself having to treat the adverse effect with another drug, be very careful in what you choose to do that with. So let's talk about lithium's role in the area of treatment-resistant depression. Who wants to start us off there? Who wants to say something about lithium's role in treatment-resistant depression? Let me see here. You have your notes in front of you there. Let's hear from, I haven't seen Evelina. I've not heard from you today. And Ashley, I've not heard from you today. And Chinmay, your camera's off. Go ahead. Who wants to start us off there? The role of lithium in treatment-resistant depression. Put your hand icon up when you're ready to roll.
Hi, it's Ashley.
Hi, Ashley. Go ahead.
I can find my hand up. So the main, it is used in the gold standard as a treatment resistant depression, especially when the patient has suicidal ideations. What it does, it helps modulate the glutamate neurotransmitter.
Mm-hmm. Yes.
And then
it modulates neurotransmission and intracellular pathways for signaling. So yes, it does inhibit glycogen and glycogen synthase kinase, which is the enzyme that leads to the breakdown of the various neurotransmitters. So it's also neuroprotective.
So it has like protective properties, yes.
Right, good, good. So that is the role. It is well established in it. When you're augmenting treatment-resistant depression, you may not be shooting for a therapeutic drug range as much as an effect. What net effect are we having? But again, I'll say, don't forget to do the therapeutic drug monitoring as well as the downstream effects. This enhances efficacy of antidepressants, particularly in treatment-resistant depression, working synergistically. We typically used for acute mania. It's supposed to reduce the recurrence of depressive and manic episodes. So that is seen as, if you don't have more episodes, we see that as a success. And we typically don't come off of the lithium. Even if the thyroid gets deranged, typically they will leave people on lithium and treat through the thyroid situation. So just be careful. The only other time you might come off the lithium is if they're toxic, dehydrated, renal failure. You got to watch out for that. I had one person that demineralized his bone and developed a pathological fracture. He was in his 20s on lithium and clozapine. And so we had to take him off lithium. Pavi.
Just to add, and I'm sorry if someone's, but just in particular, if someone is voicing suicidal ideation or has very high suicidal risk, see it added on a good amount, or like after someone has gone through a course of ECT, not during, but after, just adding it on to sort of, again, prevent relapse.
That's exactly right. You're exactly right. It's used often in treatment-resistant depression after ECT to quote unquote maintain the gains that they've made. The other thing is it seems to reduce impulsivity and aggression, which is the way by which it can reduce suicidal tendency. So that's the mechanism by which it does that. And there are studies that support it. So if someone's feature is severe suicidality or they've had a past attempt, there's a good chance they're going to wind up on lithium. The problem with lithium is because of all the monitoring, it's really hard sometimes to find a provider in the community that's willing to prescribe and maintain it. A lot of psychiatry now is done tele and remote, and a lot of psychiatrists do not want to pick up lithium or clozapine in their population because of the intensive monitoring that's required. A lot of them also won't do valproic acid or anything else that requires therapeutic drug monitoring. So that's why you'll see this uptick in second-generation antipsychotics, because they're approved for monotherapy and there's no therapeutic drug monitoring and the half-life is long. It's just easier to do remotely. So that's another reason you may find disposition problems in your population.
Professor, just to correct me, with the lithium, we can't abruptly stop it. Like say if they're starting to come toxic, or is it something where we will have to titrate down before we discontinue?
No, you could abruptly stop lithium. I mean, depends on why you're stopping it. Why would you abruptly stop lithium?
Because they have reached toxic levels. So
you have to.
Yes, that's what I was saying. In that case, you would just abruptly discontinue it.
Because think about what's going to happen if you abruptly stop it. When it's toxic, that level is still up. So technically, you haven't really stopped it.
Gotcha.
Yeah. Remember, first do no harm. And sometimes you do have to pull meds off. There are a few meds I'll mention to you here that you have to stop. One of the other big ones, of course, is lamotrigine, used for mood stabilization. They start having Stephen Johnson. You need to come off that drug yesterday. There's another condition, Brugada, which I'll get into later on, but that you need to, let's go, get off. Because the adverse effect is death. So you kind of have to stop it. How does buspirone work when it's used? Who's familiar with buspirone? What's your experience with it? Tell me the mechanism of action and what are your thoughts on it? Go ahead, Taylor.
So from the notes, I know it's a partial 5-HT1 agonist. It's used for regulating mood, anxiety, antidepressant. It's also considered, but the big pros of it are that it's not sedating and there's no risk of dependence or discontinuation syndrome.
Exactly right. Exactly right. Go ahead, Chanel. Do you have something more to add to that?
Yeah, just because we'll have addiction medicine clinic. So when patient comes to us on benzo use disorders, while we're tapering their benzos down, we're also augmenting them with the buspar, and it seems to be effective in tapering them off the benzos.
That's remarkable. I think it's one of the most underutilized medications for whatever reason. I don't know if they didn't have good enough marketing or what, but the problem with it is it's this 2 to 4 week lead time before you get good effect from it. It's not an instantaneous swap 1-for-1 thing. And most people don't have this patience of 2 to 4 weeks. So that's something to keep in mind, which I think is what makes it more underutilized. But the side effect profile is quite benign. It's not enjoyable. So the street value is 0. So it's just a matter of, do we have patience? So one of the tricks to do is to bring the patient back a little more frequently so that you can provide the necessary support while we're getting them therapeutic on this medication. Let's see here. Let's talk about mirtazapine. Mirtazapine acts differently at low versus high doses. Who wants to take a crack at this and maybe shed some light on it for us? Very common medicine used in the elderly. Why? What's going on here? Sharon.
I believe mirtazapine in low doses is good for insomnia and anorexia.
Yeah.
But then it's for in higher doses, which is more therapeutic for depression, it actually sort of counteracts the sedation effect. So it's less sedating.
You venture to guess why it's sedating? What's going on there?
I would have to check my notes. So it's a potent H1 receptor antagonist, which causes the sedation.
Right.
And then with the dose increase, the noradrenergic effect become more pronounced, which counteracts the sedative effects caused by the H1 receptor blockade.
Exactly right. So this drug is classified as a noradrenergic and specific serotonergic antidepressant, an NASSA. It is the only one in its class, so we don't ever say that about it. We just call it mirtazapine. We don't ever refer to it by its class or mechanism of action. And this blocks alpha-2 adrenergic autoreceptors, and that's what increases the release of the norepinephrine and serotonin. But it also antagonizes 5-HT2 and 5-HT3, and that's the part that reduces the anxiety and nausea, but it also doesn't have a bad sexual side effect profile as a result. So that's why this one is generally well tolerated. It also does not have a lot of drug-drug interactions, so it's preferred in the elderly. And for another reason it's preferred in the elderly, this one does not seem to cause SIADH. So most of your drugs, the SSRIs, SNRIs, antipsychotics, etc., all of those set the stage for possible SIADH, especially in women and elderly people. This one does not. The other one that does not is bupropion. So keep that in mind when you need a non-sodium deranging medication. Bupropion and mirtazapine are your friends here. Go ahead, Chanel.
What's the highest dose that mirtazapine can be prescribed at?
So you will see all kinds of cockeyed doses, but in general, the manufacturer does not recommend going over 45 milligrams, but I have seen people at 60 and 80 milligrams. I don't know that there's a therapeutic effect there. Normally, it's cowboy psychiatrists that do that. They feel they're doing something. The hard part is, of course, getting it covered because insurance will only necessarily pay for it at certain doses. But I don't ever need to go above 45. And my most common dose is 7.5, truth be told, because I don't believe I'm treating depression. I am treating poor sleep and poor eating. And then when they sleep better and eat better, the depression tends to get better on its own. Sometimes I go to 15 or 30, but not usually. And the 15 or 30, the toss up there is, are they going to start eating less and not sleeping as well? That's the thing I'm worried about when I raise the dose, because the sedating effect and the appetite stimulation effect reduces when I go up on it. So I really need people to eat and sleep. So that's why I'm reluctant to leave that low dose. But it can be done, especially if they have anxiety symptoms that are more paramount once they start eating and sleeping. It's not approved in children, but it's commonly used. And I'll tell you where I have used it in, quote, children, but more likely adolescents, is when I was dealing with the cannabis-induced hyperemesis situation. Short term, not even long term, just maybe 2 or 3 weeks, and then we stopped. Go ahead, Joanne. Off label, obviously, because nothing on label for that.
Yes. In my practice, most likely the prescriber, they give them like 7.5, very low dose. Very low dose, and the maximum 15, most of them.
Yeah, that's exactly right. So you generally tell people to take this thing at bedtime so we can promote sleep, and so that's worthwhile. Obviously, if they're eating like a champ and they are gaining large amounts of weight, then you're going to have to decide, do I come off? And you're going to need to monitor for metabolic syndrome, hyperlipidemia, hyperglycemia, etc. If they remain at that dose. The option is you raise the dose and see if that gets better, and they hold on to their therapeutic gains. So let's talk about lamotrigine in bipolar disorder. Lamotrigine's role in bipolar depression. Who wants to take a crack at this? Go ahead, Sora.
So it helps in bipolar depression, not necessarily mania though. It helps that's what you would want if someone is maybe pregnant, because it doesn't it's not teratogenic, it doesn't transfer as much in breast milk. And if people are having like it has lesser side effects also in other capacities. So you might want lamotrigine there as opposed to something like lithium. Like you don't have to worry about the therapeutic. I mean, you do obviously have to worry about therapeutic dose, but the range is much wider.
The range is wider. We're not doing therapeutic drug monitoring with lamotrigine, and also the teratogenic effects, if it's being used in women of childbearing age, are definitely worth considering. What's the downside of it, though?
Evelyn. That Stephen.
Yeah, the
Stephen Johnson syndrome.
Stephen Johnson rash.
Evelyn, what else do you think is clinically a downside in this drug, knowing what you know?
So see, lamotrigine. Well, because it's a second generation antipsychotic. Oh no, sorry, it's a mood stabilizer. It's not a second generation. You would have to, let's see,
liver.
Watch the CYP metabolite.
Well, no. So here's the problem with this clinically makes this drug difficult is the titration schedule. The titration schedule here is very slow. You basically, in weeks 1 to 2, you're only at 25 milligrams a day for 2 weeks before you can move that dose. And then week 3 to 4, then you can go to 50 milligrams a day. And then in week 5, you can go to 100. And in week 6 and beyond, you can go to 200. So the problem is we're not even near a therapeutic dose for 5 to 6 weeks for mood stabilization. So that's the problem with this medicine, lamotrigine. And then at week 6 and beyond, you could be at 200 milligrams a day. And the other problem with this drug is if the person goes off of it for more than 5 days, you have to start all over again.
Okay.
You can't just go right back up to where they left off. And you have to start the titration again over 5 days. Now, the other thing to keep in mind is people with bipolar, in the meantime, need something else to be on while we're getting to this therapeutic range. And most commonly, you'll find valproic acid because it's a therapeutic drug level. It's cheap. It's readily available. The problem is when you co-administer lamotrigine and valproic acid, you need to cut the dose of lamotrigine in half, which means good luck trying to cross-titrate. The other thing is, the reason you do that is because, not for the lamotrigine's sake, but it's driving up the valproic acid level. So you may get to toxicity and adverse effects and derange the liver just because you make the valproic go up when you put lamotrigine in the system. But you're going up on the dose. So what are you going to do? If you're going to cut the dose in half so you don't make them toxic on the valproic, if you start the lamotrigine, remember to, at the same time, come down on the valproic, and remember to check those half-lives and liver functions and serum drug levels as you move through this process. So it is doable. I have a patient right now. She's 80 years old. She's on lamotrigine and valproic acid. I didn't move beyond 50 milligrams of lamotrigine, and I dialed down her valproic, and she seems therapeutic on both. So I'm not moving, but she's having good effects. I haven't had to hospitalize her in a year. But I have to monitor her. She's elderly, so that's a problem. I'd love to put her on lithium, but she's convinced it's going to kill her kidneys, even though they're normal. I'm not going to fight City Hall. We'll do what works. As long as I can keep her out of the hospital, that's the goal. What else do I need to tell you about here? So lamotrigine, also with enzyme inducers like carbamazepine, this dose may need to be increased. So you have to be careful when you put various inducers and inhibitors in the system that you look at the effect on these other drugs that you may be cross-titrating. The short and the long of it is most people will just not do this combination. It's not that you can't do it. If you do it, you have to be careful and pay attention to inducing and inhibiting the pathway and the therapeutic drug levels of, say, other drugs that are in the system. And yes, thank you for the Stephen Johnson. Now, let me talk to you about this. This is a condition Nobody's doing EKGs as a screener, but you should know that this lamotrigine affects the sodium channels. There is a congenital heart anomaly called Brugada syndrome, and this is a genetic condition affecting the sodium channels in the heart. So that means any sodium channel blocker, you need to be careful, which can predispose this person to a fatal arrhythmia, specifically ventricular fibrillation. So why do I tell you this? You want to avoid lamotrigine and other sodium channel blockers in someone that, say, has a diagnosis of Brugada syndrome, but they don't know if they have Brugada or not. So you're going to ask, are there any history of unexplained syncope in you or your family? Because if it's in the family and this is a hereditary condition, you may have it. So you may want to consider a baseline EKG in this person before you start it, or a cardiology consult. And you want to interrogate, really, is there a personal or family history of the arrhythmia? And also any known or suspected what they call channelopathies. Channelopathy means things like the sodium channel is afflicted for some reason. And this is going to be passed down in family histories. They may not know this about themselves, but suffice it to say, if you're going to consider this medication, you need to ask about fainting, palpitations, family history of sudden death, known heart conditions before prescribing, and if there are any red flags in your consult to cardiology, spell this out. I am worried for Brugada given the history reported of fainting, blah, blah, palpitations, and I'm considering lamotrigine. And that's what you're looking for in these cardiology clearances. People send clearance and consult requests and don't spell out what they're looking for. And then the doctor will say to the patient and make you hate you at the same time, I don't know why you're here. What do you want from me? What were they thinking? So this is why you want to spell out. Brugada is more common in Asian men and presents often in the 3rd to 5th decade of life. A type 1 ECG is present and clinical criteria. That's how they confirm the diagnosis. I'll show you the picture here. Go ahead, Kurt. What's on your mind?
Just wanted to ask, what do we, oh, there you go. You showed it to us. What do we see in like the EKGs,
Yeah,
like ST
there you
elevation?
go. Right. So the baseline EKG with the right precordial lead and leads V1, V2, V3, often placed higher on the chest, 2nd and 3rd intercostal space. This increases the sensitivity of picking this thing up. Now, I don't know many psychiatrists that do this. They send it out. But if you are in the family psych world like I am, and I have my portable EKG machine, I slap that thing on you right there and off we go. You can do a drug provocation test with this, where they give a sodium channel blocker under direct cardiac monitoring. That's one way to do it. And then they do a host of genetic tests to investigate this. For your own knowledge, don't need to know, but it's SCN5A, that's the mutation. And it's only about 20 to 30% of cases that test positive for the mutation. So the problem is it's less likely done because that means 70% of the population could have this and not have this gene. Electrophysiology can weigh in on this. The take-home message here with respect to Brugada pattern, you're looking at this coved ST segment elevation and a negative T wave. So you could see the ST segment is like a cove and the T wave is negatively inverted in V1 through V3. That's where you're going to see it. Now, you're not reading EKGs per se, or you might be. Routine EKG screening is not standard of care for this. This is just for you to raise your index of suspicion. If your lamotrigine patient tells you they had a syncopal episode after starting it, that might be a reason to stop it and get them into cardiology. So I just need your index of suspicion raised so that when they say things to you, you know, oh, I remember Ray said something about this. Let me get you in the right referral. Let's get you off this. Let's put you on some other 2nd generation and off we go. Right? So one of the things you do if you're going to start a practice is make a relationship with someone that can do EKGs for you and read them, at least so you can monitor your QTCs, or you have a relationship with their primary so that you can do that. But this is something to think about if you're ever thinking about being in a private practice on your own. You are responsible for the safety and well-being. This is one way to contend with that. Where are we here? Okay. Why don't we take a 10-minute break now and come back? We'll finish this up and then we'll do psychosis. So let's do a break for now. All right, why don't I get us started with this question here? How is thyroid hormone T3 used in depression? I'll tell you about this here, and then we'll move on to the next question. But essentially, the role of T3 is often used as an augmenting agent in patients with an incomplete response to their antidepressants. So specifically, you might be on an SSRI or a tricyclic, and then you may then have a T3 put on to augment. Now, this was recommended by the APA STAR-D guidelines as a second or third line strategy in treatment-resistant depression. The way this works is this enhances monoaminergic neurotransmission, which possibly intensifies or accelerates the effect of the antidepressant agent. So what this does, it's not fully understood, but this is believed to increase serotonin receptor sensitivity so that whatever you're on works better. It also enhances catecholamine activity. And over time, we're hoping that neuroplasticity as a result of more BDNF in the system will develop. And so hopefully we'll have new neural pathways. So when do you consider this? Well, if they're a partial responder after an adequate trial, or they have residual symptoms like fatigue, psychomotor slowing, low mood. If you happen to draw thyroid levels, which you should in your process of ruling out an underlying medical condition, which is step 3 in making a psychiatric diagnosis, the subclinical hypothyroidism like TSH is normal, but the free T4 is low. That would be a subclinical hypothyroid. That might be someone you want to augment with this. The other one is the atypical depressive features. If you remember from 777, I told you what atypical depression looks like. That's someone you can think about. Starting dose is 25 micrograms a day, can go up to 50 a day, though most respond just fine at the lower doses. It can be combined with the antidepressants, SSRIs. This is not something you would do as monotherapy. Now, you need to be careful because there's going to be a lot of functional medicine types and other people that will say, oh, no, you just need to get on your thyroid medicine, and that will be the deal here. Well, if you don't have low thyroid, then we don't need to treat it. The only one you might want to do monotherapy in with this is if you are indeed treating a subclinical hypothyroid state. But keep in mind, you're no longer in your field. You've just ventured into endocrinology. So if that's what you want to do, refer them to endocrine. So that means for you in psychiatry, this is not a primary monotherapy agent. This is rule out an underlying medical condition. Dear endocrine, please consult on this patient with subclinical hypothyroid that was found in a workup for depression. I would like to see if managing the thyroid, the subclinical hypothyroid state affects mood rather than me starting an antidepressant at this time. I look forward to your et cetera, right? That's how that's going to go. And so this way you can rule out the underlying medical condition. Meanwhile, there is a role for you in the psychotherapeutic aspect where you bring them back, develop a routine, establish a schedule. This is the one you're sending for exercise and nutritional counseling and, recreational and leisure activities and that sort of stuff so that you can hopefully start doing so that the feeler eventually catches up with the doer. So you're going to explain, of course, anytime you do something off-label, it's worth doing. It's a pretty low-risk drug. So for that reason, it's underutilized. Now you know about it. You can put it in your arsenal moving forward. Joanne.
Professor, can you, I think I missed it about the T4. If it is low, it's a red flag?
No, it's not a red flag. That's how you diagnose subclinical hypothyroid. Normal TSH.
All right.
Yeah. Okay. Good. So who wants to jump in on this question here? When might psychostimulants be used in depression? Go ahead, Chinmay.
When you like feeling tired, you want more concentration or more energy, you want to add the psychostimulant.
Right. That's exactly right.
Yeah.
And in low dose. Normally, you don't need to go over 5 milligrams in the Ritalin with this, right? And be careful in the elderly if you do this, because you have to contend with the cardiac side effects that come along with it. So just be mindful of that. This was Freud's claim to fame, essentially. He did cocaine for everything. It was legal then, and it boosted the mood, and it led to productivity, and everyone felt great. The heart attack was a bummer, though. Okay. Here, we're going to talk about ketamine and S-ketamine mechanisms of action. This is the same drug, just different sides of the same isomer. Who knows about ketamine? It's all the rage. Who aspires to own and operate a ketamine clinic? Tell me all about this here. Who's it used? How does it work, and who's it used for? Joe, hey.
Hey, so I'm not looking at the notes right now, but I believe ketamine just boosts the neuroplasticity of the brain, so it allows your brain to form better connections faster. So the treatment modality that should be used with ketamine is intense therapy during and around the infusion. I think that a lot of these online sites now have gotten like this like fad thing about shooting it up your nose via a nasal thing. Or I've even had friends out. They have it prescribed in lounges for their depression, and they're using it in the club and stuff like that.
Yeah.
So it's really crazy. But
So
yeah, it's
you're
supposed to be
exactly
able to
right.
help you form those bonds.
It is. Do you know what class it is?
No.
Okay. Why don't you go look that up and report back. Go ahead, Sora. Let me hear from you.
Oh, one of the things I was going to point out about ketamine is that it's supposed to have a really rapid effect, which is part of the draw of it. And one of the ways that you can tell if your ketamine clinic is sketchy is if they deliberately give suboptimal doses so that people keep coming back, because this isn't, I mean, people do wind up on it for a long time, but if you're acting in the patient's best interest, you shouldn't be having them on it for years and years.
So I don't want to blame the clinic that starts off with low doses as being suboptimal, because it does, and the nasal spray is not bad. So actually, Escalith, which I'm sorry, not Escalith, esketamine, which is a Spravato essentially, that's what's approved by the FDA for depression or treatment-resistant depression. It is now becoming approved as a monotherapy standalone drug. So in theory, you should be on an SSRI. That's how it used to be. Now you can do it alone. Some people will start always at the 54 milligrams before they go up to the 84 milligram dose, and maybe you want to do that a couple of times. The major adverse effect with this is the hypertensive emergency. Some people do get nauseous. Some people get a profound tachycardia. So some things to keep on hand if you're going to do ketamine therapy is some sort of short-acting oral beta blocker, and also some sort of antiemetic. So ondansetron is fine. The other thing is, if it does cloud sensorium, I would recommend you should have like a nasal trumpet in the office so that if you lose the airway, you have a way to get it back. Most people don't do that. That might just be my background ICU, where I assume everyone's dying until proven otherwise. But that's kind of my approach. If I'm going to do ketamine in the office, we're going to have in the office a beta blocker, an antiemetic, a nasal trumpet, and I'm debating if we should keep an AED handy. That's not in any of the guidelines, but you should know that this is not a benign drug. And Joe, you're exactly right. This thing is all over the place in the compounding world. COVID made this such that it's being made and manufactured and shipped in lozenges and patches and sprays and freestanding ketamine infusion centers and the like. All of that is off-label. The only one that's actually approved for treatment-resistant depression is the Spravato nasal spray. That's it.
And
everything else off-label.
It's classified as a dissociated anesthetic, which makes sense because
it's an NMDA receptor antagonist.
Yeah.
And so why that matters is, if you had me for 777, I told you about medical conditions of underlying psychiatric manifestation, medical conditions that have psychiatric manifestations. One of the conditions was NMDA receptor encephalitis. So if that is in your differentials because they're acting psychotic and you forgot to rule that out, and for some reason you think ketamine is good for them or Namenda is good for them, you need to be very careful, because they have an anti-NMDA receptor antibody, and that will make them more psychotic. So be careful. So just keep in mind that this is very popular. It's gaining a lot of traction. It's very lucrative. The other thing to keep in mind is the monitoring. So when you do this nasal spray, the manufacturer recommends a 2-hour post-spray monitoring period. So now you can tell why this is not very commonly done in the traditional psych practices, is it occupies the room for 12 hours, and you need to monitor pulse ox and vitals after you give this spray. So suddenly a psych practice may need a medical assistant, or suddenly a psych practice is occupying a lot of space. And so as a result, to make up the difference, that winds up raising the rate. So some people will bill the patient at the cost of 2 sessions for every ketamine infusion, because you're taking up space for 2 hours essentially. And so then they decide, do I make this a ketamine practice where all they do is ketamine? But my problem with these practices that only do one trick is that everyone that walks in the door gets the same trick, whether they need it or not sometimes. So that's the same as going to one of these online telepharmacies. You will get sold whatever it is they happen to be selling as a solution to your problem. So buyer beware, clinician be informed, and let's go to the next slide here. So let's talk about this major situation. And Eugene, you mentioned this early on, so I'll ask you to answer this one. How do you recognize and treat psychotic depression?
I would say you would look for symptoms of both depression and psychosis, maybe like some kind of hallucinations or delusions, and I would give them both antipsychotic and antidepressive, maybe like Effexor and Seroquel or Zoloft and Zyprexa.
Yep. And then what else is the last line? Or first, could be secondary treatment for this situation. Psychotic depression people are typically admitted. They typically get admitted if you have psychotic depression. What's another option you could offer these people?
ECT?
Yeah, that's the other one. That's the fastest, biggest bang for the buck. If they're psychotically depressed, you want to move in that direction sooner than later. You can always stop it, but it gives the most robust response. So that's something to think about. And of course, it might have to be done over objection. So that's another thing to figure out as well also. How is catatonia identified and treated? Who wants to tell me about catatonia? Catatonia. Is it like porn? I'll know it when I see it. Go ahead, Joanne. Catatonia. Tell me about that.
Yes, catatonia like is a specific behavioral symptoms. They have different kind of symptoms. For example, at work, I see them. They have stupor, waxy flexibility, multisms, negativisms, and posturing, mannerisms, agitation, and then most likely the provider they use benzo, but ECT is a gold standard.
Yes, it is. So there is a benzo test where you just give them a 2 milligram IV push, or it's like IM, but IV push is nice too. And you should see a rapid response within minutes. If they respond to that, they may use that as a positive test. There are some objective measures you can use to monitor catatonia, and it can be hypoactive or hyperactive, but it's something to keep in mind to be identified. Joanne.
Yes, I have a question because we have a patient at this time. Like patient is selectively mute, so we believe it's catatonia, part of it. But I'm wondering if they are like malingering, can they use catatonia as a as a
If they malinger
strategy?
with catatonic
Yes.
symptoms. Yes,
I'm wondering because I said to the psychiatrist, do you think this guy is catatonic or is malingering? So how to differentiate between both?
Well, look for the secondary gain. Malingering is quintessentially defined by doing it for a secondary gain. So figure out what the secondary gain is. If he gets the secondary gain and he improves, and when you remove the secondary gain and he gets worse, you may have answered your question. The other thing is you said selectively mute. Selectively mute is not the same as mutism. Selectively mute, this is a maladaptive coping mechanism to severe anxiety. So children will do selective mutism if they feel their voice can't be heard in whatever setting they're in. But mutism is essentially just mute all the time, all domains, not selectively. So just be careful about that. Yeah, if you're getting selective mutism in an adult, you can go down that path of might this be malingering. But figure out what the secondary gain is, see what happens when you give it and remove it. And if it improves or doesn't improve, then you'll know. He may be doing secondary gain for the benzo, though, too. Keep that in mind. So as the benzo challenge becomes a problem. And if it's persistent, you might need to go to court for ECT. You might have to subject this poor man to ECT. It's unfortunate, but it is a diagnosis of exclusion. There are some objective criteria you can look into. There's some rating scales and the like. So
that's the plan for the provider.
You can also do things like EEG and brain scanning and get a neuro consult and that sort of stuff as well to get a second set of eyes.
All right.
What defines atypical depression and how might this be treated? Who can tell me about atypical depression? Searing, I've not heard from you.
Okay.
Not you, Siri. Tell me about atypical depression. How might it be treated?
Atypical depression is like hypersomnia and mood very low.
Mm-hmm.
And you treat with the MOI or SSRI?
Yeah, but you still haven't told me how do you distinguish it from whatever we call regular depression. That's what I'm looking for you to do. Tell me the difference between atypical depression and how do you identify it? You said hypersomnia. What are some other things that make this known to you?
Has no.
Go ahead, Cleo. What do you got? Cleo, go. You're on mute, Cleo. Cleo, you're on mute. Let me hear from Sharon until Cleo figures out the mute button.
I think the difference is that it's more reactive in that positive events can make the person feel better, whereas in more major depression, it doesn't matter if there's a positive event or something good is happening, the person is still going to be anhedonic or still going to be depressed.
That's exactly right. They're highly reactive to the environment. So the hypersomnia is a factor. The other thing is hyperphagia and rejection sensitivity, meaning, oh, those are great shoes and they light up, or oh, why did you do it like that? Or, oh, you're eating a lot more. Typically with depression, you have poor sleep and poor appetite and indifference to the world around you and general apathy. But the atypical side of this is I'm sleeping too much, I'm eating too much, I'm sensitive to rejection. And these people typically, bupropion, they do say MAOIs, but it would be interesting to know that a lot of people also conceptualize this as a personality disorder. That depends on what school you're in. If you're from the Cornell school, they lean into the personality disorders nice and hard. But and the two are not mutually exclusive. You can have personality traits as well as this atypical depression. Okay, let's go on. What do we do to manage depression and anxiety with agitation? This is a popular thing. Psych gets consulted a lot for agitation. Kurt?
So I would guess start with like a calming antidepressant, like an SSRI, escitalopram, mirtazapine, and avoid, I guess, excitatory agents like bupropion, fluoxetine, and then start low with your dosing. And I don't know, maybe even consider maybe like a short-term anxiolytic, lorazepam, if they're agitated.
Yep, all of that is good, but make sure we don't forget about short term. When you ever say start a short term something, I want you to get in the habit of specifying in your note, what do you mean by short term? Specify that so that nobody leaves them on the benzo until you come back from vacation, and then we can't get them off now. So specify. And in general, I'd say no more than 7 days. Some people say 14 days, but I think that's too long. 7 days. They're going to really enjoy it in 14 days. What helps prevent relapse after ECT? Someone mentioned lithium earlier. Who was that? And tell me more.
That was me. I don't know the mechanism for how it helps to prevent relapse after ECT, but the fact that it's used in treatment-resistant depression can help with suicidality. Specifically, it sort of makes sense for those reasons. And yeah.
Yep. So this is good for relapse risk post ECT, and about 50 to 80% of patients, just so you know, will relapse. 50 to 80% of patients will relapse within 6 months after a successful ECT if no continuation treatment is initiated. Continuation treatment could be medication or maintenance ECT. And what they'll get is a recurrent mood disorder, psychotic depression, treatment-resistant depression. So you want to do for the first 6 months post ECT some sort of relapse prevention treatment to sustain those gains for at least 6 months, and then spend 3 months coming off with that gradual taper, and then you can be done and see if they're done with the depressive episode. So you want to either resume or initiate the antidepressant immediately after ECT course is done. You know, it's 3 times a week for 3 to 4 weeks, and then after that, start the treatment of whatever it is. Venlafaxine is preferred in preventing relapse post-ECT, especially for treatment-resistant depression. Lithium has strong evidence as well, lithium with the venlafaxine. Again, remember to do the therapeutic drug monitoring. Also especially useful if they were to the point of being suicidal, and that was the reason you went for ECT. Also, if you're dealing at the depressive phase of a bipolar episode, lithium is good there too. For psychotic depression or bipolar disorder, you can do continuation treatment with quetiapine, olanzapine, lurasidone, all of those second generations, but those 3 in particular. And then the other thing is, who do you really want to consider this on? If someone's doing ECT and this is not their first rodeo, so if they've had multiple relapses despite meds, severe or psychotic depression, or they're intolerable to meds, then those are the people that may actually be referred to what's called maintenance ECT. And maintenance ECT is done weekly to every 2 weeks to maybe once a month, just depending on that titration schedule. But keep in mind, every time you go in for ECT, it's the equivalent of a pre-op clearance procedure. NPO after midnight, repeat EKG, physical exam, check labs, all the things, because obviously you're getting some anesthesia and sedation for this. So you want to follow mood symptoms, cognitive recovery, and their adherence to the pharmacotherapy. And don't delay restarting the medications, because that leads to the biggest risk. So that means working out the pharmacy, the delivery, the pickup, the follow-up appointments, all of those sorts of things. The FDA approvals for bipolar disorder, you can just tell me the class here. Who can tell me the class? Go ahead, Cordell.
It's lithium.
Say again?
Lithium.
That's not the class. That's just one of the mood stabilizers. The general class that's approved is the second generation antipsychotics, right?
Psychotics.
Right. So lurasidone, quetiapine, olanzapine, cariprazine, lumetrozole, all of those. And some people will do the combination, something called Symbyax. In the early 2000s, Prozac came out bundled with olanzapine together, and they said that would be approved for bipolar. The problem is it makes you eat too much and gain weight. But suffice it to say, they take that same SSRI and second generation antipsychotic and apply it. So you can combine SSRI, second generation antipsychotic, but Symbyax is approved as a standalone drug, which is a combo of fluoxetine and olanzapine. And Joanne.
Yeah, I just have a question. Is Sembax a popular drugs? Is
Say
it
again?
popular? The Sembax, the combination. Is it popular or not?
It was when it came out, but the combination is popular.
Oh, okay.
You can combine fluoxetine with olanzapine, but I don't see anyone on Symbyax, and people were afraid to
Yeah, I don't see them.
People were afraid to put people on an SSRI if they had a history of bipolar. And why might that be, as it leads into this question here?
What's the question, Professor?
The question's on the screen. Why are we worried, or would people be worried about putting someone with bipolar on SSRI? Kira.
So if someone's having a depressive episode, and especially if a clinician just thinks that they're experiencing MDD, they might start them on an antidepressant, and it can trigger a manic state for them. Yeah.
Which is called treatment emergent affective switch. That's what that is, by the way. That is what you would look up in the literature, treatment emergent affective switching. That's the antidepressant induced mania, which is more likely to occur in bipolar with mood stabilizer co-treatment. So that's why they combine it with that second generation antipsychotic. What is rapid cycling bipolar, and how is that managed? And it's important that you know this definition so you don't confuse this with borderline personality. Joan.
Basically, the patient might have 4 or more mood episodes like manic, hypomanic, or depression within 2 months, 12 months?
Within a year, yeah, within 12
Yeah,
months.
yeah,
You want to avoid antidepressants in this group if they're rapid cycling, and you'll use things like valproic, lamotrigine, lithium, or second generation antipsychotic. All right, so just be careful. So mind you, it's greater than 4 in a year. When someone does greater than 4 in a day, that's not bipolar. That's very likely borderline. And so that's one way to tell. No matter how big the demonstration is, it doesn't mean it's a severe condition. Rapid cycling is phases in a year, not phases within the hour or a day. What neurotransmitter is involved in mood and impulse control? So I'm going to move through these questions now. These are things you may see on your test applied in some way. So what neurotransmitter is involved in mood and impulse control? 5-HT, dopamine, norepinephrine, GABA, and glutamate. So pay attention to that list I gave you, because we've got one more lesson after today and we have the final. So there's a reason I have lots of questions up here. Your answers to them will help you study for the final. So you should be able to answer these. And just to give you an idea, you want to be able to answer a question well enough that you could explain it to a patient or a family member. So if you want to study for your exam, teach your layperson family member all about what you're learning. If they understand it after you explained it to them, you're doing great. How do you match symptoms to neurotransmitter targets? So again, what symptom are you going after? That's the target you're going to choose. So if your main thing is apathy, dopamine agonist, norepinephrine reuptake inhibitor. If your issue is anxiety, that's 5-HT and GABA. If you're dealing with insomnia, GABA melatonin. Agitation, a 5-HT2A and a dopamine agonist. So what am I talking about here? We're talking about essentially dopamine, so bupropion for the apathy. We're talking, and the way you know it is, what is apathy? I'm giving you this for apathy, meaning you have low motivation, indifference, decreased goal-directed behavior. That's going to be our target when I pick a dopamine agonist, right? So that's how you can tell. What's your symptom? Anxiety. How will I know it? Are you having excessive worry, muscle tension, restlessness, irritability? Okay, got it. That's the symptom we're going to target. I'm going to spell those things out. Don't just assume they know what anxiety means when you say 5-HT for anxiety. Spell it out. Excessive worry, muscle tension, restlessness, irritability. So that's kind of what you're aiming for. And if that's your patient that you're treating, you're talking SSRIs and SNRIs and the first line to target that. Avoid the benzos. They are useful, they are prescribed, but you want to avoid them. If your main symptom is insomnia, you want to use gabapentin. How will you know? That's difficulty staying asleep, falling asleep, or early morning awakening. Now, the first line, as you know from 777, is CBT for insomnia. Mind you, that's not what people do. They like to run to a pill, but it's much more effective if you can implement that CBT. But basically, we're talking things like melatonin, gabapentin, maybe a little trazodone, hydroxyzine, that sort of thing. And if you're targeting agitation, we're dealing with things like restlessness, emotional lability, pacing, verbal or physical aggression, which is the most common reason psych gets consulted, by the way. So this is helpful if you are familiar with the neurobiology of agitation and restlessness. Also, make sure you've ruled out delirium when this is reported to you. But essentially, we're dealing with 5-HT2A overactivity. There's too much dopamine in the system here. And so we're going to use things like the atypical antipsychotics. You want to get them off the activating meds and the stimulant meds, calm environment, establish routine, circadian rhythms, that whole sort of thing. So you always want to start with the dominant symptom cluster, with the caveat that you always want to go after sleep first. We need to make sure that the patient is sleeping and sleeping well first, and then go after the dominant symptom cluster. Usually poor sleep, if it's in the equation, is the dominant symptom cluster, because once they sleep, the rest of this may regulate and follow. So please do that. Don't go chasing how you feel until you're getting them to sleep first. How might SSRIs be augmented based on side effect profiles? What do we think here? So someone says, oh, I'm on my Celexa and I'm having sexual dysfunction. What might you do? Go ahead, Kurt.
Bupropion?
Good. Add bupropion to augment it. Or if it's early enough in the titration schedule, you could maybe switch to mirtazapine, right? So you can augment or switch, depending. Good. And then also second generation for poor responders with residual symptoms. So, if you've targeted it with the SNRI and they're still restless and agitated, or you put the mirtazapine and they're still restless and agitated, that might be the one you want to think about augmenting with a second generation. What pharmacologic approach do you do with OCD? That falls into this as well. Go ahead, Joan.
I will start with SSRI, fluoxetine.
Yeah, you could start with fluoxetine and work your way up. The one that actually works really well but is not commonly used because it has a lot of drug-drug interactions is fluvoxamine.
Oh.
It's quite old, but fluoxetine is good. And you're talking high dose. We're talking on the level of like 200 for sertraline and maybe 100 for fluoxetine. So that's how high we're talking. But you have to go reasonably slow because the GI side effects can be quite bad, and then they'll want to abandon ship but you're going to take a while to get up there. So you're going to have to manage until you get to that therapeutic dose. Trichotillomania, there's no official drug for this. There is a nutraceutical that's approved called NAC, which is the glutamate modulator. NAC is being implicated in gambling disorder, any sort of compulsive behavior, hoarding, gambling, sex, hair pulling, skin picking. That combined with the SSRIs, maybe SGA, second generation antipsychotics, and behavioral therapy. All of that can be done. You're going to have to go with what the patient is willing to allow, essentially. And the process will be slow because you can't underestimate the power of a habituated behavior. So what about intermittent explosive disorder? This is quite popular if you work with child and adolescent populations. Here, give me a pill, medicate him. Sora, you were right in saying this. Essentially, what if we're just treating the family through the patient? But what medications do you see them use for IED? It's funny, improvised explosive device, intermittent explosive disorder. That's kind of what I think of because the kid's going to go off at any moment and everyone walks on eggshells. Go ahead.
We use mood stabilizers a lot. Like I've seen valproic acid be very successful.
Yep. That's the big one.
That's the main one that we use. Sometimes things like depending on their other comorbidities like lithium or Abilify.
Right. So the other big thing is they may also use like the catecholamine blocker. So you might see an alpha blocker or a beta blocker also be in there, especially if you're going to raise some mindfulness. In other words, if you get the kid to figure out what happens before you blow your lid. Well, my heart rate races, my skin starts to sweat, I get hot in the face, and then I explode. Great. Here's what I want you to do. The next time you feel the heart rate racing, let me know, and mom will give you this little Inderol, and hopefully we can keep the heart rate from going up, and then hopefully we can keep you from exploding. That's kind of how that goes. Does it ever work out that well? No, because oftentimes the parent is not in tune enough to even realize that, and the kid's exploding and they just want him sedated at that point. So this is where the family systems work tends to be a factor. What's the pharmacologic and trauma-informed approach to NSSI? That is non-suicidal, self-injurious behavior. What do you do here?
So
what's the drug we're giving these people? Yeah, Sora.
So we have a lot of this on my unit as well. And in order to figure out what drug, you have to find out what the root cause is of the non-suicidal self-injurious behavior. Are they self-harming because they're feeling overwhelmed, in which case you would give them something for anxiety? Or, what else is going on? And you would want to CBT and DBT a lot, and slowly work down from whatever they're doing to less and less and less. Like if they came in cutting themselves with glass, hopefully by the time they leave, they're only scratching themselves.
Right. So you made an interesting observation. You got to find what the underlying cause is. And I'm going to tell you, it's always some form of anxiety. It's just their maladaptive way of contending with it. The anxiety can be triggered by, I'm bored. Boredom, I was amazed to learn, is a huge trigger for a lot of people to start engaging in this sort of behavior. Because if they're bored, they're alone with their own thoughts. They can't just block from the environment. So they're not sufficiently distracted. So I tend to find a lot of overlap between NSSI and addictive behaviors. There tends to be something needing to medicate away. And the way they're dealing with the anxiety is through avoidance. How are they avoiding? Well, now they're cutting and we're focused on this. We're not focused on this monster I've created in my own mind. So I tend to find that to be the consistent theme throughout. SSRIs are definitely used to kind of mute the feelings across the board. Second generation antipsychotics for the impulsivity. You validate the distress, and then you want to see if they're doing some sort of trauma disassociation. And if they are, then you might want to work on that. We don't have to explore the whole trauma. We want to build in coping mechanisms. Not everyone needs to emote and tell their story. Sometimes you just want to teach them ways to cope with it. Why is CBT preferred for compulsive hoarding? I'll just tell you this, because it targets the belief about the possessions. I don't find this effective unless you have high dose SSRIs that they're willing to take with it. Otherwise, they have a very organized, delusional, and maladaptive coping state, and it tends to be maintained. So these are things that don't officially have indications. They're in the DSM, and people want to prescribe for these. So take a look at this. Rationale for kleptomania. What do we do for kleptomania? Think about what these diseases and conditions have in common with respect to their circuitry. In order for someone to do a maladaptive behavior, they need to get a hit of something. Go ahead, Evelyn.
That's what I was just going to say. Their reward, their urge to have this reward.
That's exactly right. You need to think about this in terms of what is it you're getting out of this. And so what you want to do, same with compulsive drinking, compulsive gambling, compulsive sex, compulsive stealing, etc. Sharon.
I was going to say dopamine.
Yeah, I need a dopamine hit. So what we're going to do is we'll put them on an SSRI and naltrexone, because I want to block the dopamine hit that comes with the kleptomania or the binge drinking or the sex or the gambling or the whatever. So SSRI with naltrexone, and then sometimes you may actually put some bupropion in the system to help reduce the craving as well. So that's kind of how these sorts of what they call process addictions are being managed. How can Maslow's hierarchy guide the treatment planning? This is just a repetition. I'm telling you, you always go after sleep first, that sleep and eating first. That's the physiological needs. And then you go after safety for affective regulation before you go after the cognitive work. So you can conceptualize Maslow's hierarchy of needs as to what order you want to go in for what symptom you want to treat. So pull up the pyramid. It's in the book. You can take a look and see how you want to proceed with that. What's the difference between impulsivity and compulsivity? This is neurologically mediated in different parts of the brain. That's the main difference here. The upshot of all of this is it comes down to still SSRIs and second generation antipsychotics. But impulsivity is orbitofrontal cortex and dopamine dysregulation. Compulsivity is anterior cingulate. The compulsivity is around rigidity. You see rigidity symptoms. I have to wash my hands this way. I have to act this way. I have to correct the truth in everybody. I can't control myself. You'll see a lot of autistic people manifesting compulsive behavior. And so you want to treat them like, hold it in like a fart. Don't be going out there correcting the world, or you are going to find some negative feedback, and then you'll find yourself in isolation because no one wants to be around that personality on a regular basis. So you can medicate it, but now you know. We've done this already, matching the targets. How do we taper SSRIs? Slowly, and we can use fluoxetine to bridge. How would you explain SSRIs working in terms of neuroplasticity? We're just recapping now. What happens? How does this work? Show me you've paid attention. SSRIs in terms of how they work with respect to neuroplasticity. Suyin.
Yeah, it increase BDNF, and then
right.
It can help with the neuroplasticity.
Right, exactly right. The BDNF stimulates neurogenesis and then neuroadaptation. That's exactly right. So that's what I want you to take home from this. So the mood disorders impulsivity theory, here we go. The theories of depression. You have the monoamine theory. This lacks evidence and it's debunked. Look at the Monserf article. The newer focus is on BDNF, neuroplasticity, and inflammation. So you're going to see a lot of people offering you anti-inflammatories for depression. All theoretical. Antidepressant classes are here. You have the SSRIs. They're typically first line. Fluoxetine is the long prototype with the half-life. There are the common side effects. SNRIs are useful for pain. Venlafaxine, duloxetine. Mirtazapine is good. It's sedating at low doses and boosts the appetite so you can get good sleep and eat. Bupropion is activating, no sexual side effects, used to augment sexual side effects. If you're on an SSRI, you want to be careful with bupropion in seizure disorder. It lowers the seizure threshold over 450 milligrams. I never give anyone anything more than 300 XL. I have not found it to be any more beneficial, and the risk is just not worth it to me. The tricyclics and the monoamines, these are effective, but they're very high risk. So you want to be sure that your patient is not suicidal or on a lot of comorbid co-offending agents when you do this. And just remember to have a good washout period, and you need to monitor for cardiac adverse effects. The augmentation strategy summary here is lithium reduces suicidality and has good efficacy for that. The second generation's for augmenting mood disorder, so they're on something, not fully responding. Aripiprazole is a popularly used one. It's the least metabolically deranging, and it does not prolong the QTC. In fact, it shortens it. Other ways to augment include thyroid, psychostimulants, ketamine, and these can be very niche or saved for severe cases. Impulsivity and compulsivity. Impulsivity is linked to dopamine and orbital frontal dysregulation. The reason that matters is your approach will be different. So impulsive means I do something without thinking. Compulsive means I do it and I can't stop thinking about it, and I need to let everybody know about it. So the compulsivity is linked to serotonin and cingulate overactivity. So you might put the compulsive person on an SSRI. The impulsive person may be on a second generation antipsychotic. Pharmacologic targets of SSRIs for OCD and hoarding, NAC for trichotillomania, and propranolol if you can raise sufficient awareness that they can bring the heart rate down and act differently, essentially. The treatment framework, Maslow informed, so the base of the pyramid, the goal is to restore sleep, appetite, and energy. The middle of the pyramid ensures safety and reduces agitation. The goal is you want to build trust. The top of the pyramid, this is the cognition stuff, the trauma, the insight. That's when you have enough coping mechanisms in place. So remember to match the symptom to the neurotransmitter and use the meds to support neural recovery, not fix a serotonin imbalance. Any questions on mood? Okay. What we're going to do now is we'll take a 10-minute break again, and then we're going to come back and we're going to do psychotic disorders. This is going to be one of our longest days just because we have one more to go.